Hello friends, welcome to our second and last video in bone marrow transplant series of videos. Friends, in this video, you can expect the answers of questions that patients and their family members, including the donors, want to know. The answers are going to be in very simplified manner which anyone can understand. Friends, if you have not seen our first video, I highly recommend you to see the first video as well. To see the first video of series, you can click on the first video button in top right corner of your screen. You can also find the link in the description box. Before we start the discussion, friends, my name is Dheeraj Sharma and I am bringing this video on behalf of medical experts. Today, to answer the common questions of family and donors, we have Dr. Suraj with us. Dr. Suraj is hemato-oncologist and bone marrow transplant expert. He is from the Mumbai branch of SCG group of hospitals. SCG is one of the leading hospital chains of cancer care. Friends, apart from being associated with SCG group, Dr. Suraj has been active in conducting multiple research and he has published many research papers both at national and international levels. Dr. Suraj, welcome to the Medical Experts channel. Dr. Suraj, I would like to start today's session with the patient's family's biggest curiosity. And that is, what is the forward path after the bone marrow transplant? Is there any medication after BMT? And if yes, how long the medication will continue?
As we understand, as we told, donor stem cells will reside in the foreign body. The patient body will always see the donor stem cell as a foreign body, and donor stem cell will see the patient body is the foreign. So both of us will start fighting inside the body. So to stop those fighting, we need to give immunosuppression. The duration is different in different condition. If we see non-cancerous condition, we give for longer duration from 9 to 12 months. For cancerous condition, we usually stop beyond 6 months, but in some cases we can stop after 3 months also when we have a very good results. So it depends on the type of problems and what target we are trying to achieve. So, but if you understand broadly, patient will require immunosuppression for at least 3 months, and it can go for at least 1 year to 1.5 years in few conditions.
Understood, Dr. Suraj. So 3 months is the minimum part and 1.5 years could be the maximum. Average, we can say 3 months to 9 months it may be required for most of the cases, and extreme cases it can go for 1.5 years or so. So, Dr. Suraj, when the benefits of bone marrow transplants are visible, so one is definitely the procedure part, then the recovery and acceptance part. So one man can significantly feel the visible impacts of the whole procedure, be it in energy level or symptoms level.
Yes. So when we do a transplant, so as I told, the reboot takes some time. So, but if you see, we do transplant we have a certain order of blood test and bone marrow test we do post-transplant in different condition. If you see the non-cancerous condition like thalassemia and sickle cell anemia, mostly if the procedure is successful in thalassemia, then the patient won't require a blood transfusion after almost 2 months of the transplant. After 2 months of transplant, if successful and the patient has tolerated very well, almost after 2 months he might not require a blood transfusion. There is reverse actually. Sometimes what happens in thalassemia, once they achieved a good hemoglobin, their hemoglobin can shoot up to high 15 to 16 and those people are keep absorbing the iron, so we need to remove it. in thalassemia. So such a transformation happens with the transplant. Everything change in thalassemia. Thalassemia children are usually growth retarded. They have less attention deficit. They have attention deficit because of persistent low hemoglobin. They are having the less concentration, less growth. Diabetes like problem happens at a young age. So these all things been reversed with bone marrow transplant. Not except the hematological, the other changes also happens. So these are in thalassemia perspective. In malignancy, the main aim of transplant that the stem cells should be replaced with a healthy, and the disease wherever it is hidden had been killed by those healthy stem cells. So in the disease like for example AML, I am giving you example. We do a bone marrow after the 28 days of transplant to see how good response we have achieved. So we do a minimum residual test also, disease test. We told in short form MRD test to see what remaining of the cancer cells are remaining. So that is almost after 1 month. So cancerous conditions, if MRD is negative, the chances of getting better is very high. So the symptoms and most of things, transplant has the immunity issues mostly started to sort out after 3 months. After 3 months, they been doing well. Then the chances of infection, the symptomatic relief from the disease perspective are very very less complications. So if you say roughly after 3 months, if nothing happened, mostly the period is uneventful in most of the patients.
Great. Thank you, Dr. Sir. So the next question is, this is more from the perspective of the malignancy cases. So the patients are always having this worry that what will be the life expectancy one should have in the mind when undergoing the bone marrow, because one, it's a relatively a costly solution, and cancer being cancer, there is a possibility of a reoccurrence always. So what is the kind of a life expectancy you have seen in a malignancy cases?
So basically, I will divide this. Every disease has a different nature, how it reacts. So basically, if I tell, we will keep a broad-based range. So in malignancy, mostly the bone marrow transplant can cure in 50 to 70%, depending upon the disease and the stage at which we have done the transplant and requirement of transplant. So in such data of patients, if we try to analyze this 50 to 70% of cure rate, means patients are doing well post-transplant after 5 years as well. So if we see less than 5 years, 50 to 30%, 30 to 50% people may not do well. In that patient having transplant related complication, their disease has come back, all those complications. And reverse, if we see 50 to 70%, the patient tolerate well, their disease won't come back, and they are living happily and cured. So the chances of all those things for 5 years is 50 to 70% in cancerous patients.
In non-cancerous patient, is it a safe assumption because there is nothing called a reoccurrence of diseases? The life expectancy can be as normal as any human being?
Yes. So in non-cancerous condition, because if we see thalassemia, the abnormal proportion of hemoglobin to carry out our function, if it reaches to 60 to 70% also, the patient can be having a very good healthy life with normal lifespan. So if there is a problem, means sometimes 100% stem cells also not started once working, if they work for 85-90% also in those cases. So because the body produces enough of hemoglobin, so they have a very good life. So if we see this in non-cancerous, almost around 70 to 80% patients feel very well in non-cancerous. But in cancerous things, what happen, even if these 10% defective stem cell are there, they will rapidly grow and they will kill the normal cells in future. So that worry is not there in non-cancerous condition. That's why they have very good cure rate, symptomatic relief, the quality of life is way better.
Understood, Dr. Suraj. Dr. Suraj, the next question is, we have discussed in between our in this session, what we understand that there are broadly two kinds of transplants: autologous and allogeneic. Right? These are the terminologies which are coming pretty frequently.
Absolutely.
So, would like to understand more autologous, allogeneic. One, by the description, it's understood. One is own and another is a foreign. In which conditions autologous is preferred and which conditions allogenic is preferred? And you may like to elaborate autologous and allogenic for our audiences once again to have a better understanding.
Yes. So actually, as you rightly said, allogenic is from somebody other's body, someone's body. We need to take the stem cells, while in autologous, the self stem cells will try to collect. So in allogenic, there are various type of donors. Mostly the donors which are useful as siblings donor, means brother sister. Then if they are not matching, then second option is we have a different type of registries also, where just like a blood bank, there are HLA registries where we upload the HLAs of patients. If we have a donor, there are Indian Datri registry, then German DKMS, NMDP registry in US, UK registry, the Chinese registry. There are various registries are there where lakhs of people has already registered, so we can see if any HLA's matching is there or not. Third, if both are not there, there is a half match transplant also there, where the children or parents of the patients can donate the stem cells, because this is the most recent advances in transplant. Because sometimes we see the kidney transplant, liver transplant, if you don't have a donor, what you will do? You don't have time also in hematological problems. So these problems have been overcome with the half match transplant. That is happening because we have now understand the pathology of various disorders and how transplant works. So currently with the medical advent, there are a lot of good medicines are available. If we are utilizing this medicine to make the haploidentical transplant successful. So if you tell 100% match donor is successful, initially the chances of successful of half transplant is 50% compared to a full match donor. But now with the all precautions, trained staff, medicines, the environment, we have almost achieving a result 80 to 85% as good as a match sibling donor transplant. So this is the most advancing field in transplant, because with the half match, everybody will have a donor. Means most of the Indian population or foreign have either parents or children to donate the stem cells. So these things is taking a very big leap in this transplant world.
Understood. So if I need to summarize, friends, for you, then in allogenic there are three kind of donors. One is the siblings, which are, I would say, the most preferred one. Then the next preferred one is going to be haploidentical, which could be the parents, could be the children's, or in some cases perhaps the cousins as well. And the third way, if the match doesn't happen, both of them would be registering into some registries where we would try to look for the match donor across the globe or across the nation. Is that a right summary, Dr. Suraj?
Yes.
So, Dr. Suraj, autologous, we want to also discuss a bit. What are the kind of conditions where the autologous is more suitable than an allogenic one?
Yes. So mostly autologous transplant we prefer now in lymphomas, myelomas. Lymphoma, we opt for autologous stem cell transplant when they have relapse of the disease. And in multiple myeloma, after giving chemotherapy, doing stem cell transplant is a standard of care. Okay. So broadly in lymphoma relapse, while in myeloma it's a standard after the initial chemotherapy. So the lymphoma, why we do a transplant is because most of the lymphomas are either chemo, immuno and targeted therapy sensitive. But there are some hidden cancerous cells inside our body that has not been reached by these modalities. So this has been done by doing autologous stem cell transplant. In autologous stem cell transplant, we give high dose chemotherapy that destroy essentially more than 99.99% of the cancerous cells in the body. And after destroying such cells, there will be destruction of bone marrow at a stage where it can be regenerated on their own. Okay, when we fight a war, sometimes the enemies also die, but we have to also suffer. It's the same like thing. This suffering has been mitigated by collecting the stem cell prior to giving a high dose chemotherapy, and we have destroyed the enemy. Then we'll reinfuse the stem cell so that it will rapidly grow and will start producing a normal cells, while at the same time the enemies means cancer cells already been killed. So this is the thinking behind the autologous stem cell transplant in lymphoma. While in myeloma, what we do after giving the chemotherapy, after controlling the initial disease, we have to do a long impacting transplant, because multiple myeloma is like diabetes. It's a chronic disease that is non-curable. Like diabetes can't be cured, myeloma can't be cured. So while the autologous transplant will destroy maximum number of myeloma cells, in turn will increase the life expectancy, the quality of life and overall survival rate at a very good numbers. So autologous in myeloma is not curative as compared to the lymphoma part, but it will gives a very good quality of life, because myeloma patients are more than 16 maximum number of patients, so they will give them a very good life and long lasting fight against the myeloma.
Thanks, Dr. Suresh, for the clarification. Dr. Suresh, the last set of the questions is more from the donor's perspective, because there is a family member who is definitely involved in the donation process. So, is there any risk to a donor?
Donor are absolutely safe. I will tell, means there is no 0%, but I will tell it's a 0.00001% risk to the donor. Because anything can happen in medical. There are a lot of surprises, but the donating stem cell is as good as donating a blood. Just like many people has donated COVID plasma, it's the same process where we'll take the blood from the donor, we'll filter it, we'll collect the stem cell, and rest of things will transfer back to the donor by the separate channel. So it's just a donating blood, taking the stem cells, returning the blood to the donor. So is as simple as that. But compared to blood donation, it takes more time. Blood donation takes only 10 minutes, while the stem cell donation can take up to 3 to 4 hours. So that is only thing. And mostly patients with a simple condition like diabetes and hypertension with age less than 60 years tolerate procedure very well. We are much skeptical if the patient having any history of myocardial infarction that can put a strain. Usually we don't select such donor. For those also checkpoints are there. But if the other checkpoints are under control, the chances of risk to donor is nothing. In fact, just like we tell, for after blood donation, there will be replacement of their the blood by the body. Same, the stem cell will get again replaced in the body. So nothing to worry. It increases the speed in which the stem cells are formed in the body. So it's a win-win situation for the donor. But only thing, they have to take few injection before the stem cell collection. That will cause a body pain. That is most of the side effects. The body pain that can be mitigated by giving a simple Dolo 650 tablets. That's all. The risk is very, very less.
So, Dr. Suraj, this is, I would say, when you have taken the stem cells from the blood of a donor. What if you choose to take a stem cell from the bone marrow of a donor?
So, essentially what I told, the difference between BMT and stem cell transplant is that only. We have moved towards stem cell transplant. So 98% we are using the collection from the peripheral circulation only. Bone marrow transplant, only there are very few indications when sometimes in between any procedural problems happen and the patients requires urgent transplant. So sometimes we use a bone marrow transplant. In some few conditions like thalassemia, when the patient is very young, like 2 years, 2.5 years, that time we can take the bone marrow from the donor. So, and the third problem is, the third condition is when the donor doesn't want to donate. Sometimes there are few people, they don't want to donate through peripheral blood circulation, but they will donate through the bone marrow. So now the stem cell collection is the ideal in more than 98% of the cases. So bone marrow we do very rarely nowadays.
Understood. So even if it is done even 1 or 2% of the cases, then also is there any risk to a donor or not at all? Even
so the risk of the minor procedures is always there, like because they require the anesthesia. Sometimes we need to intubate the patient in the donor in the theater. So anesthesia related risks are always there. Those are the complications. These are there with the bone marrow transplant. So otherwise the procedure is relatively safe, because we are collecting blood from the hip bones. So there will be any pain will be there post procedure, that can be taken care with the simple medicines. And during the procedure, anesthesia related complications can be there. And that too are very less.
So I was about to summarize the same thing. So friends, from a donor's perspective, there is absolutely not a risk. If the stem cells are collected from a blood, so it is as simple as a blood donation. There is absolutely nothing to worry about it. Even if in very, very rare case, as Dr. Suraj has mentioned, if the collection is happening from a bone marrow, then only the anesthesia related risks are there, which are absolutely very minimal, and these are the risks when you go to the OT in any and every situation. Those minimal risks are always there, and there is no risk beyond that point. Is that a right summary, Dr. Suraj?
Yeah. In very lucid way and perfectly you are explaining. Yes.
Thanks. So the last question is, we have discussed the matching quite a lot. So what is this matching, and how do you identify that? What are the criteria when you say that the HLA matching is that, and what is the HLA matching first of all? Then what are the different criteria based on which you typically identify that this is the right donor, or you need to go for another donor or haploidentical donor?
So the thing is, this is means if we try to understand in simple way, just like O positive blood group donate to O positive, A positive to A positive, B positive to B positive. we do a blood grouping. For stem cell, there is a HLA. HLA means human leukocyte antigen testing. So usually we check the 5 regions. Just in blood group, we just check a blood group and whether it is O positive or O negative, like that. In that, there are 5 points are there: A, B, C, D, R, D, Q. These are points we need to check, and these are little more complicated than the blood cells because they have their various antigen also to be matched as a HLA. A match means there are various their subtypes also that has to be matched. That is the complexity. So mostly siblings are matched, and every sibling, if I am patients, I have 3 siblings, every siblings having match is 25%. 25%, how it comes? Because there are 2 pairs of chromosome in male, means father and mother. One get transmitted, so there are total 4. So the chances of getting the 2 same copies in a sibling is 25%. Means 4 copies are there, 100 by 4 is 25%. So 25% chance is there for each sibling to be matched, and that is a best. Okay, so this is a complexity. Parents are always 50% because only half they transmit. Either 50% is transmitted by father or rest is mother. But there are few conditions like whole mother will get transferred, whole father will get transferred. These are rare, but they do occur. Okay, in reality, because we done transplant where sibling means brother sisters are not matching, but parents are matching. So medical field is like that. There are always surprises. So and if you see the match unrelated, what I told, there are different registries. So for the probability, if we see a random population, if you don't have registry, to get my HLA on an average, to get a matching, I need to check 64 lakh people. That is a probability of matching. So in match unrelated, it is so high, while in cases with sibling, it is 25%. That is far better than anything. Parents are always half match. So half match donor is always a boon. That's what I am telling with the new medicines. If you see the allogeneic transplant, match sibling costs 100 rupees. Previously, it was in half match, it will taking around 150 to 175 rupees. But with the extra care, good medicine, now it cost is become also more and less same. Now it is become like 110 rupees or 15 rupees. So 10 to 15% extra. But and with the good benefits. So these are the probabilities are there in different type of transplants.
Understood, Dr. Suraj, and I would seriously appreciate the way you explained everything. I'm sure our audiences are going to love it, and it was precisely meant for the people who is not so medical and seriously curious about to know all the things. So my questions are over, Dr. Suraj, and I would like to seriously thank you for your time and your candid explanations on all aspects of a bone marrow and stem cell transplant. So thanks, Dr. Suraj. Thanks a lot.
Yeah, pleasure is all mine. I will be always there.
Sure. And friends, at any point of a time, Dr. Suraj is available, and if you want to have a one-to-one consultation to have more precise discussion with respect to your case, then Dr. Suraj is available in SCG, and if you want to have a video consultations, you can be in touch with the team of medical experts as well. So feel free to have one-to-one discussion with Dr. Suraj, and I'm sure you will have very good results. Thanks, audience. Thanks, Dr. Suraj.
Thank you. Thank you for giving opportunity.
Friends, that's the end of our video series on bone marrow transplant. Hope that you would be able to take a very informed decision now. If you still have any confusion or any other doubts, you can get in touch with us. The details are available on the screen and also available in the description box. Last but not the least, do share this video to those who need it. Moreover, friends, if you like this video, please do encourage us by liking the video. This is Dheeraj signing off, and we will meet soon in next video on some other topic. Thank you.